Mm. Uh-huh. Sir, we can start the presentation, sir.
Yeah.
You're audible. Your audio is audible to us.
Okay. Are you able to see the PPT?
Yes, sir. Kindly make it full screen so everyone can see it clearly.
Are you PPT? Bhargav, are you able to see the PowerPoint?
Yes, sir. We are able to see your PowerPoint, sir.
Are you able to see the PowerPoint?
Yes, sir. We are able to see your PowerPoint, sir.
So, good evening, everyone, and thank you for attending this webinar on Beyond Conventional Free Flaps and Head and Neck Reconstruction. I'm audible, isn't it?
Yes, sir. You're audible, sir.
So, conventionally, over the last 2 or 3 decades, most of the head and neck defects have been reconstructed with the three traditional workhorse flaps, that is the radial forearm, the ALT, and the fibula. And in most instances, these flaps suffice. And 99% of the time, if a free flap is decided, you can do one of these three flaps and reconstruct the defect. But over the last 2 or 3 decades, better understanding of vascular anatomy, perforator anatomy, and improvements in microvascular anastomosis have led several authors to explore different types of newer free flaps. Now, there are several reasons why we look for the alternate free flaps, and probably the most important reason is to conceal the donor site. If you have a radial forearm, the donor site is very conspicuous. If you have an ALT which has been skin grafted, it's very conspicuous. If you have a fibula which is large skin paddle with the graft, that is also conspicuous. And there have been some functional aspects also. For example, if you have a very complex orbitomaxillary defect, a single fibula flap doesn't suffice. If you have a multi-axial soft tissue defect in the oral cavity, sometimes if the ALT has only one perforator, you're not able to use that flap. So both from an aesthetic point of view, how the wound looks like, the scar looks like, as well as the functional point of view, trying to replace what is lost with nearly what we can do. So several reasons have helped us move forward in the search for alternate flaps. And the other important reasons are the body habitus of the patient. Several times you need a thin, pliable flap for example, tongue reconstruction or buccal mucosa reconstruction. And then you find that ALT is too thick. Even if you do thinning of the flap, it doesn't really fit into the defect. The radial forearm, the patient doesn't want because the larger the radial forearm, the larger the skin graft, and more the risk of tendon exposure. So sometimes patients, especially in the modern setting, have a choice to play in deciding what flaps that they want. And in some instances, we don't have the conventional donor sites. For example, the patient's already had an ALT, skin graft has been taken from the other side, so aesthetically it doesn't look good. Or the patient has peripheral vascular disease, we're not able to take a fibula. So there could be reasons that there is a non-availability of the conventional flaps, and you might have to do another newer flap. So the reasons are many, but you will realize the more you start having a diverse array of flaps in your armamentarium, you can decide what flap fits into that effect, rather than having to do a new flap for the sake of doing a new flap. You will be able to decide which flap fits best for a defect. So knowing the newer flaps is probably the most logical evolution in learning microvascular surgery. So these are some of the flaps that are less commonly done. I wouldn't say they're newer, But if you look at the soft tissue flaps, the thoracodorsal artery perforator flap, the medial sural artery perforator flap, the profunda artery perforator flap, the transfer upper gracillis flap, the parascapular flap, the groin and skip flaps. These are some of the soft tissue flaps that are not really done. If you look at the groin flap, it is the first described free flap, so it's not necessarily new. But these are some of the flaps that are not conventionally used in head and neck reconstruction. And if you look at bone flaps, the scapula and angular scapula I had discussed with you in the previous presentation, there are several modifications to what we can do with the iliac crest. The previous presentation I told you about the deep circumflex iliac artery flap, which is the standard iliac artery flap. But there are modifications to how you can vascularize that portion of the iliac crest. So we have iliac crest with tensor fascial lata muscle, and we have iliac crest with tensor fascial lata and internal oblique. We have the vastus intermedius flap with the femur, and just for completion's sake, I've mentioned the radial osteocutaneous flap. So getting on to the unconventional flaps, the medial sural artery perforator flap is a really good flap. It is a perforator flap, as the name suggests. The flap is from the calf, the skin of the calf. So in most patients, it's thin and pliable, and it's a relatively recent description. The skin is hairless, so it's quite good for intraoral reconstruction. The donor site can be closed primarily. So anything less than 6 centimeters, you can close the donor site primarily. And it's good for defects of the tongue and buccal mucosa. Now, there are several descriptions of how you mark medial sural artery perforator flap. What I would normally do is just take the mid point in the popliteal crease and drop 8 centimeters down, and you will be able to, Doppler the perforator in and around this territory. If you want a more extensive way of how to mark this flap, you can refer to Tao's publication in PRS in 2010. But basically, mid-popliteal crease, you drop a line, about 8 to 10 centimeters, you'll be able to Doppler the perforator, and you can center your flap around that perforator. Now, this is a musculocutaneous flap, so there are musculocutaneous perforators, which you have to do. There's this intramuscular dissection through the gastrocnemius muscle, and the pedicle is followed until the popliteal artery is reached. Now, through the course of this pedicle, there are several muscular branches to the gastroc, which have to be ligated. And if you want, you can harvest a portion of the medial gastrocnemius if you want to fill in soft tissue defects or dead space obliteration. But in the instances that I have used, it has only been for tongue reconstruction, so you can really get a thin flap, hairless flap from this area. So this is how the medial sural artery perforator flap looks like. It's quite thin. The only issue that you would have with the MSAP is that the pedicle is not very long. You might get 6 to 8 centimeters if you're lucky. And the caliber also might be slightly less than that what we see with an ALT or a radial forearm flap. So this is an instance where a tongue cancer has been resected. Here you can see how the pedicle is taken into the neck, and this is the flap after it's been inset. So this is a relatively good flap if you're looking for tongue and buccal mucosa reconstructions, and it can be done as a two-teamed approach. If you want to make the dissection bloodless, you can use a tourniquet on the thigh, and it's basically an easy flap to raise once you're able to identify the perforators. Usually it's one perforator. If you're lucky, you might get two, but a single perforator suffices for most MSAPs. So the next flap that is quite uncommon in head and neck uses the thoracodorsal artery perforator flap. Now, to understand the thoracodorsal artery perforator flap, you must know quite very well how the thoracodorsal artery system branches. And this is a perforator flap from that system. Again, the skin is from the back. It is a thin, pliable skin, which is literally hairless. The disadvantage would be that the patient needs repositioning for you to access the back. Again, the donor side can be closed primarily. And one of the nice things of this flap is that you can get a long pedicle length. Now, this is the picture of how the thoracodorsal artery arises and branches. So starting from the axillary artery, you have first what is called the subscapular artery. The subscapular artery divides into two branches. One is the circumflex scapular artery, which is important for your parascapular flap and your scapular bone flaps, and the thoracodorsal artery. Now, the thoracodorsal artery is what supplies the latissimus dorsi muscle. Along its course, it gives an angular branch to the angle of the scapula, which is the bone. You get branches to the serratus anterior muscle, and then you get a vertical and transverse branch into the latissimus dorsi muscle. And from these branches, you get perforators, which supply the skin, and that is what the dissection is all about. Now, this is an excellent article written by Jain, published in Indian Journal of Plastic Surgery in 2015. There are not many papers which describe the surface marking of the flap or how you would raise it. So they have, quite nicely simplified the surface marking. The perforator location is either 4 centimeters below the inferior angle of the scapula or 8 centimeters from the axilla. But you always palpate the latissimus dorsi muscle because the perforator enters within 2 centimeters of the anterior border of the latissimus dorsi. So you have the anterior axillary line, the mid axillary line, and the posterior axillary line. You have the thoracodorsal artery coming deep to the latissimus dorsi, giving a transverse branch and a descending branch. And from 2 centimeters from the anterior border, you will have perforators that supply the skin. Now, these are musculocutaneous perforators, and in some instances, you can have septocutaneous perforators as well. And these septocutaneous perforators are usually between the latissimus dorsi and the serratus muscle. So, the anatomy of the perforator can be variable. So, what you need to do is to make an exploratory incision anterior to the mid axillary line, elevate the skin posteriorly till you encounter the latissimus muscle, and then find a perforator, split the latissimus muscle, go to the underside of the latissimus muscle and identify the thoracodorsal artery, and follow it up all the way up to the subscapular artery if you need that much length. Now, the thing that you have to remember is that there are several perforator variations. What you Doppler may not be what you see when you raise the skin flap. Sometimes we would have marked the exploratory incision on the back posteriorly, thereby missing the perforator completely. So you might have to raise the skin anteriorly also to see if there's septocutaneous perforator arising. The pedicle length can be tailored to the desired need. You don't need to clip the circumflex scapular artery to get all the pedicle length. You can stop when your pedicle length is adequate. Thinning of the flap is possible as per the defect. And as I mentioned, you look at the picture of the thoracodorsal axis, and then if you memorize that and if you're sure of that, you will be able to raise several flaps based on that arterial system. The other flap that is quite popular, especially in Taiwan, and several people have presented about it, is the profunda artery perforator flap. Now, this is somewhat similar to the anterolateral thigh flap. ALT is from the lateral thigh, the profunda artery perforator is from the medial thigh. And it's a perforator flap again. One of the advantages compared to the ALT is that usually in the ALT, the flap is raised on a single perforator. Whereas in a profunda artery perforator flap, the perforators are multiple and they usually, in groups. So even if you raise a skin island which is small, you will be able to have 2 or 3 perforators in the same skin island. And there is a more direct course to the source vessel, unlike the ALT where you can have multiple variations of how the perforator enters the source vessel. The scar is well concealed in the medial thigh, and it can be a suitable alternative to the ALT. The problem with the profunda artery perforator as well as the tug flap, which I'm going to show you next, is that sometimes raising a flap from the medial thigh can cause some lymphedema and also causes some anesthesia of the skin in that area, which can be troublesome for the patient. So this is how it looks. Again, this is an excellent article from 2015 in PRS where they compare ALT and the fibula and the profound artery perforator flap. So the basic principle here is in the medial thigh, what you do is you first mark the gracilis muscle. The marking is as for a standard gracilis. And once you mark the gracilis muscle, you make an incision along the anterior border of the gracilis. You then work in the space between the gracilis muscle and the adductor magnus muscle. You might see a subcutaneous perforator between the muscles, but in most cases, it is a perforator which comes through the adductor magnus muscle. And this needs to be dissected to the source vessel, that is the profunda femoris artery. So it is more or less more direct dissection compared to the ALT. And probably the most important aspect of this flap is to work between the space of the gracilis muscle and the adductor muscle. So this is how the marking is. You first mark a line from the pubic symphysis to the medial epicondyle, go 1.5 centimeters below that, and that is your gracilis muscle outline. And then inferior to the gracilis muscle, using a handheld Doppler, you Doppler the perforators, and then you center your flap around it. And then you start dissecting the perforator that enters the skin through the muscle all the way up to the source vessel. And this is how the flap looks like. And again, just like the TDAP, this flap can be thinned to your requirement. And even small flaps will have multiple perforators, thereby making it more robust. So the profunda artery perforator flap has been used for predominantly tongue reconstructions. And the advantages, as you can see, is that even for subtotal glossectomies, if the bulk is required, you can take the flap without thinning, and the donor site is hidden, and the flap is probably more robust because of the multiple perforators. Now, an extension of the tug flap, extension of the profunda artery perforator flap in that area-wise would be the transverse upper gracilis flap. Now, this is not a true perforator flap like the others that I just described. It is a flap that has the skin and the gracilis muscle, and it works really well for total glossectomies. Because of several reasons. The skin gives you good volume so that it is able to be protuberant and you're able to get palatal contact. The muscle can form the oral floor and the diaphragm, and the nerve that supplies the gracilis, that is the obturator nerve, can be attached to the hypoglossal nerve to keep the muscle, retain the tone of the muscle. So the supply of the tuck flap is basically from numerous perforators that enter the skin through the gracilis muscle from the medial circumflex femoral artery. And it's usually about 1 to 2 finger breadths below the inguinal crease, the groin crease. So you've got to, skin paddle has to be quite high. And the maximum width is how much you can pinch the skin and close it together. So the upper incision is about 1 to 2 centimeter below the inguinal ligament and the gluteal fold. And this is usually, this picture is for breast reconstruction, but this is what you usually mark and harvest. And this is how the perforators enter the skin. But since this is not a perforator flap, you really don't have to dissect the perforators out. You just have to make sure that the skin is not elevated off the proximal gracilis muscle. So this is a total glossectomy patient. This is the valvular mucosa. This is the specimen that has been excised. This is the tuck flap that has been marked. And here you can see the skin paddle is not raised off the muscle at all. So you use the skin paddle for the neo-tongue and you use the muscle to recreate the oral diaphragm. This is how the protuberant tongue looks like. And this is how the floor of mouth is reconstructed with the muscle. And another way of insetting the tuck flap, this is from a paper published from Italy, where you do the hyomandibular suspension, and then you fold the remaining gracilis muscle posteriorly, and then the skin paddle comes superiorly where there is enough bulk below the skin paddle to form a protuberant tongue. So the tuck flap is really good for a total glossectomy. It is very vascular, it's very robust, and you get good muscle and a nerve to be able to maintain the tone of the muscle after nerve coaptation. Now, the next soft tissue flap that is really underutilized is probably the parascapular flap. I mentioned to you the arterial anatomy of the subscapular system and thoracodorsal. From the subscapular artery, you have the circumflex scapular artery, which curves around the scapula here at a place that is called it's a triangular space bounded by the teres and the long head of the triceps. So this vascular muscle space is where the circumflex scapular artery gives off the perforators to the skin paddle. Now there are two perforators. You can either have a transverse perforator, so the skin paddle can be marked transversely, or you can have the descending perforator. You can mark a descending skin paddle. So there are some advantages to this flap. That is, you have good pedicle length. The skin is thin and pliable. It's hairless, and the donor site can be closed primarily. You can combine it with bone and muscle components because here you can see that one of the branches that you clip during a skin-only parascapular flap is the periosteal branches. And it is these periosteal branches which supply the lateral border of scapula. So this flap can be raised as a skin flap by itself, either with a transverse skin orientation or a descending skin orientation. And you can combine it with the standard scapular bone flap if you wish. So this is again a more expanded view of the how the subscapular system works. So the raising of the flap is quite simple. You mark the triangular space here. The triangular space is between the teres minor, the teres major, and the long head of the triceps. You can Doppler this area and get a Doppler signal, and this is the transverse branch, and this is the descending branch. You start distally and start elevating the skin of the rhomboids and the infraspinatus muscle. As you come closer to the triangular space, you will see that the artery or the vascular perforator entering into the skin paddle. And once that is done, you free the branch that goes into the skin paddle. You clip the thoracodorsal artery, you clip the periosteal branches, and then you follow this all the way up to the subscapular artery and take it off at its origin from the axillary artery. So you have to clip the periosteal branches, you have to clip the thoracodorsal artery, and you can follow the subscapular artery all the way to the axillary artery. So this flap is really simple to raise. It is very quick. The only problem is that you have to reposition the patient, and with its periosteal branches and the thoracodorsal continuation, there are several other flaps that you can harvest along with the parascapular skin flap. The next flap is the groin flap, otherwise the superficial circumflex iliac artery flap, and it was the first free flap that was described in microvascular reconstruction. And with the advent of the other newer free flaps, its use has really faded. There is some issues with the groin flap, namely the caliber of the vessel and pedicle length. But the advantages are that it offers hairless skin, which is thin and pliable, and the donor site can be closed primarily. It is still used for covering hand defects following degloving as a pedicle flap. But I have done very few of these as a free flap because there is a problem with the vascular anatomy and its variability. This is a simple way of harvesting the flap, which is from microsurgeon.org. Basically, the superficial circumflex iliac artery rises from, the course is below the inguinal ligament, 1 to 2 finger breadths below the inguinal ligament. And you're raising this as an axial pattern flap, axial pattern free flap, meaning there is no perforator dissection. So you make an elliptical skin incision just above the inguinal ligament with about 2 centimeters below the inguinal ligament here. You raise the flap from lateral to medial. The key point here is that once you see the lateral border of the sartorius muscle, you incise the deep fascia of the sartorius muscle and work deep to the deep fascia of the sartorius. And once you come to the medial border of the sartorius, you will see the SCIA vessel. And then the SCIA vessel can be followed up to the femoral artery and taken off from its origin. Now the harvest looks simple enough, but the problem is there is a lot of variability in the anatomy and the pedicle length, and there are several issues with that. So this flap has moved, and what we now do is the circumflex, superficial circumflex iliac artery perforator flap, otherwise called the SCIP flap. Now, the difference between the SCIP flap and the groin flap is that in the SCIP flap, we use the perforator from the SCIA vessel, and then we use the perforator with a small amount of pedicle for our microvascular anastomosis. And this was described by Koshima for limb defects. Now, the problem with this flap is that you're going to have a short pedicle length. If you use a superficial set of perforators, you might have a longer pedicle length, but whatever said and done, the caliber of the vessel again is quite small, and there could be issues with microvascular anastomosis. So SCIP flap, maybe 2 or 3 articles published for head and neck. The advantages, like I mentioned, is that you can close the donor site. It's relatively hairless, and with the SCIP, the anatomy is a little more consistent, but it's a difficult flap to raise, and I wouldn't recommend it for all unless you're quite good with doing small vessel anastomosis. And there are a lot of papers which have showed the harvest technique of a SCIP flap. Each of them are quite different, and I never knew which one was the right one to follow. But this is a video that you can get on YouTube, published from Queen Victoria Hospital by Dr. Berner. And it is quite different from how the conventional SCIP flap is described in literature. I would strongly urge you to watch this video for you to understand. That the way that he raises the flap is that he exposes the superficial branch of the SCIA first, make sure that the pedicle is intact and a good caliber and length, and then he raises the skin island without really looking at the perforator. So this is a good video to follow if you want to learn how to raise a SCIP flap. Now that completes the alternate skin flaps or the fasciocutaneous flaps that are available. Now, what are the alternate bone flaps that we have now? Now, if you look at the need for alternate bone flaps, the reason why alternate bone flaps came into vogue is because the fibula had some inherent disadvantages. The problem is the fibula has relatively fixed skin pattern, meaning that you cannot resurface 2 mucosal surfaces which have been lost, or you cannot resurface a mucosal and a skin surface which has been lost. So it is quite difficult to get a large skin paddle to resurface 2 cutaneous or mucosal defects. And the pedicle could be problematic because if patients have uncontrolled hypertension or peripheral vascular disease, they have issues. So that is what led to the exploring the newer or trying to identify other sites, potential sites for bone flaps. So I had already described to you the DCIA flap in the last presentation. Now, how is the iliac crest perfused? Now, the conventional iliac crest perfusion is by the DCIA, that is the deep circumflex iliac artery and the vein, which forms the basis of the DCIA flap. And this runs along the inner aspect of the iliac bone. And if you want to raise DCIA flap, you've got to raise the bone by incorporating the DCIA branches, which supply the periosteum of the iliac crest. And this is how a normal DCIA flap would look like with the internal oblique. But there are other alternate ways to vascularize the iliac crest also. And one of the ways to vascularize the iliac crest is to use the periosteal blood supply through the muscular attachments to the iliac crest. And one of the muscles that we use is the TFL muscle. The TFL muscle is there in the lateral thigh. It attaches itself to the iliac crest, and it is perfused by the transverse branch from the lateral circumflex femoral artery. So the iliac crest, based on the muscular attachments of the tensor fascial lata, can be made vascular. So you can get about 2 to 3 centimeters of bone based on the attachment of the tensor fascial lata muscle. And this tensor fascial lata muscle is perfused by the transverse branch of the lateral circumflex femoral artery. So you don't need to take the DCIA pedicle. You don't need to violate the abdominal wall. You don't need to dissect the DCIA vessels. So by using the TFL attachment to the iliac crest, you can get a vascularized iliac crest for reconstruction. Now, where does that come? Where does that where is that useful, or where does that come into during the reconstruction of the head and neck? Imagine if you have a complex orbitomaxillary defect. For example, this patient has had total maxillectomy, orbital exentration, loss of skin of the cheek, and obvious loss of the palate. The conventional reconstructive option in this patient would be just to use an ALT to cover the whole defect, or to use a fibular flap for the alveolus and the skin for the palate, and another flap like the forehead flap to close the cutaneous defect, or two free flaps. But if you really want to do a complete reconstruction on the patient, we need to think about putting teeth back, that is dentition, and to get an ocular prosthesis into the patient. Now, to get an ocular prosthesis into the patient, you must reconstruct the orbital floor, and you must recreate the orbital cavity volume. So this is where understanding the iliac crest blood supply and understanding how to harvest a chimeric flap from the iliac crest becomes useful. So this is an article that we published from our department. What we did was we combined two flaps. That is, we combined the DCIA with an internal oblique supplied by the DCIA muscle, and the TFL left attached on the outside with its lateral circumflex femoral artery, and had two anastomoses done, two flaps, that is one TFL flap and one DCIA flap, and the bone of the iliac crest reconstructed the orbital floor as well as the alveolus. So this patient had an ocular prosthesis. The skin was covered by the skin of the TFL flap. The muscle went into the orbit to fill up the orbit, and the TFL muscle went into the palate to resurface the palate. So a complex orbitomaxillary defect, and when planned for a complete reconstruction, ocular and dental rehabilitation, you might be forced to use the iliac crest with two different flaps altogether, and you may have to do two separate anastomoses. The other area that you can use the iliac crest perfused by the TFL muscle is when you have an isolated orbital floor. You can always argue that we can do a fibular flap in this instance, but the fibular flap, the dissection is longer. There are several potential pitfalls of the fibula. This is relatively easier to do. So this patient had an orbital floor defect, and he did not want a bone in the alveolus. So as I mentioned to you before, you can take 2 to 3 centimeters of the iliac crest, leave the attachment of the tensor fascial lata muscle on the iliac crest, and use the transverse branch of the lateral circumflex femoral artery and do the anastomosis. So the iliac crest can be used in different ways to reconstruct complex orbitomaxillary defects. Now, the radial osteocutaneous flap is not very commonly used because it's got significant donor site morbidity. Probably the area that it's most commonly used is in pre-maxillary reconstructions, where you need a short segment of bone. You take the bone between the pronator teres and the brachioradialis, along with its septal attachment to the skin. You only take 1/3 circumference, and you have to be careful that this doesn't fracture. So it's not very commonly used, but it's worthwhile remembering when we consider the different types of bone flaps. The final bone flap that I want to describe to you is the vastus intermedius along with femur free flap, which is a very recent description. Probably over the last 10 years, there have been 2 or 3 papers that have been published on that. This is based on the same vascular supply of the ALT flap, but using the branch to the vastus intermedius muscle. And this vastus intermedius muscle is attached to the femur. So if you can harvest the femur bone along with the vastus intermedius without disturbing the connections or the periosteal attachments, trace the vascular pedicle of the ALT flap, you will be able to raise the vastus intermedius femur flap. Now, this is one of the pictures showing the harvest of this flap. Now, this is an ALT flap also that is harvested because it's the same vascular pedicle. And here you can see this is the vastus intermedius and the attachment of the muscle to the femur bone here. Now, again, you have to take less than 1/3 circumference of the bone If you take more, or if you breach the medullary cavity, there's a high chance that the femur will fracture. And this sits quite well for mandibular defects. Again, the two-team approach is possible. Anatomy is reliable. There is wide separation of components. You can harvest a traditional ALT skin flap along with it. You get long bone stock. The donor site is acceptable, but we need more studies to show that it doesn't affect load bearing on the femur. And it is a suitable option when double flaps are needed. And this is how it looks like. So this is the intermedius muscle attached to the femur. This is the same vascular pedicle going to the ALT and a common descending branch of the lateral circumflex femoral. Another flap, probably in the interest of knowing what can be harvested from the thoracodorsal pedicle, is the serratus anterior rib flap. Now, the serratus anterior attaches to the ribs, and the branch of the serratus anterior comes from the thoracodorsal artery. So, in cases where you need a widely separated skin paddle and a bone segment, you can take the thoracodorsal artery, use its two branches, that is the one going to the latissimus dorsi and one going to the serratus with rib. You can use widely separated branches for mandibular reconstruction. But you must remember that this doesn't bear too much of the load, so dentation is an issue. But these are growing bones, so if you're planning for a growth center transfer, a serratus muscle with rib is good in pediatric patients. So for bone defects, the newer flaps probably are more suitable for orbitomaxillary defects, as I had shown you. So DCIA alone, DCIA with TFLIC, that is tensor facial arter and iliac internal oblique, or tensor facial arter with iliac crest. And if you have multi-axial defects, probably the scapula and the ALT with femur. So in conclusion, thorough knowledge of alternate free flaps proves useful when conventional options are unavailable. A majority of the alternate soft tissue flaps have concealed donor site. Understanding perforator anatomy is essential, and so is the ability to do small vessel anastomosis. Because if you're not able to do small vessel anastomosis, it might be difficult for you to complete successfully the free flap transfer. Alternate bone flaps are needed when the fibula is contraindicated or is unavailable. And some of the alternate bone flaps also provide multi-axial soft tissue cover, which may be useful for complex oromandibular or orbitomaxillary defects. Thank you very much for your time.
Hello, sir.
Yeah.
Thank you, sir. Thank you for the nice presentation. Shall we take the questions, sir?
Yeah.
Yeah. Sir, our first question is from Dr. Abhimanyu. What pedicle length we get for TUG flap for a total velocity defect, for which the recipient vessels do you generally anastomose?
You get about 6 centimeters at the most for the tuck flap, and then you keep the facial artery and facial vein long during the neck dissection. So that will compensate for the shorter pedicle length. So you can use the facial artery and facial vein.
Okay, sir. So our next question is by Dr. Deepak Khanna. So what is that you take on maxillary reconstruction, ELT, scapula, or fibula?
For maxillary reconstruction, we've always used the fibula. If the reconstruction is confined to the alveolar process, then the fibula is the flap of choice, because you have long pedicle length, you have the ability to do osteotomies, you have skin for the hard palate. So fibula is the flap of choice for a standard maxillectomy. The only issue comes when you lose the orbital floor also. So if you lose the orbital floor, either you use an orbital mesh and cover it with the FHL muscle, or you osteotomize the fibula to form the orbital floor. So the fibula is the go-to flap for maxillary reconstructions. The only place, like I'd shown you, where we would think of using a double flap is when the skin of the cheek also is lost. That may be an indication for the TFL iliac crest internal oblique flap.
Thank you, sir. Sir, our next question is by Dr. Neena Iravati. Can
Mhm.
we implant Rohner procedure on alternative bone flap such as iliac crest free flap?
I don't know of any literature that has shown that, because the um, the fibula, the good thing is you're able to image the fibula. You can see the thickness of the fibula. You can plan the distance of the implants on the fibula. It's all done virtually. So I think the current technology exists for doing it on the fibula itself, because the iliac crest, usually you don't usually osteotomize the iliac crest. You only corticotomize the iliac bone. So I think the Roner is best suited for fibula alone, and I don't think it's, at least from my understanding, it has been has been described for the iliac crest or for the other things.
Okay, thank you, sir. Next question is by Dr. Hanpoon.
Because just to add to that, because in the Rona technique, you actually expose the bone, you put the implants, you cover it, and then you go back after some time and then you harvest it. I haven't seen any videos or any literature showing the same thing for Capilla or BCIA. So I don't think it's developed yet or has been reported yet.
Thank you, sir. So next question is by Dr. Hanpoon. Uh, some literature reports more venous congestion in MSAP. Do you experience any problems with MSAP?
I don't think so. I mean, if the vein is large enough and if you've done anastomosis to a suitable vein in the neck, I don't think congestion is a problem, because it forms the same physiological thing as a usual normal perforator flap. So, no, I don't think there is an issue with the MSAP.
Okay, sir. Thank you. So our last question for today is by Dr. Abhimanyu. He has given us a patient scenario. The patient has multiple primaries over last 10 years. They have exhausted both ALT, one RAF, and one PMMC. Now they had to do with a total lobectomy defect with a failed gracillis flap. So his question is, what to opt for, one more free flap or one more PMC? What would you do?
What is the status of his neck vessels?
He hasn't mentioned as of now, but I feel that they might be exhausted also.
So, if in the
Depleted. He was saying just vessels depleted.
see, the issue is that if you do a total vasectomy, unless you give the patient a protuberant tongue or a tongue with good volume, he's never going to be able to be without tubes. He's never going to be able to, try to vocalize and things like that. If the patient has got a very thin pec major and the skin is thick and the patient is emaciated, it is very bad, because once you put such a pec major into the oral cavity, all that you get is a flat diaphragm there, and whatever you give the patient, he will aspirate. So if your free flap is giving you more bulk, and if you have even vessels in the lower neck, you can do a CT angio or you can Doppler. If you can find vessels in the lower neck, for example, the transverse cervical vessels, if you're able to, if you need to just find one artery and the IJV. That's all you need for the anastomosis. If you have the external carotid, you can use the external carotid straight away. If you have the IJV, you can do an end-to-side IJV. So if your free flap is giving you more bulk than the pec major, then I wouldn't mind taking the risk of doing a free flap, so that the patient is functionally rehabilitated, and leave that pec as a salvage procedure in the end. With regards to vessels, as long as you have one artery and the IJV, that's all you need to do for microanastomosis. So try a free flap first. If that fails, then do a pec. But if the pec has got really good volume and it's bulky, go for the pec up front.
Okay, sir. One more question, sir. A new question from Dr. Thapa. When Dr. Thapa has used mesh for orbital floor support, there was
Yeah.
extensive fibrosis around it and it has extruded. So he had to remove it. So what is your experience in it?
Yeah, so the issue is how you place the mesh. There is a way of, see, there are preformed meshes and there are meshes that you cut out of that slab which Orthomax provides you. It's better to use the preformed, pre-bent meshes, because the why it was extruded was because there was some irritation between the mesh and the skin anterior. You have not bent the mesh well enough to slope down that contour. So putting the mesh slightly posteriorly and avoiding any sharp corners and using the pre-bent meshes are better than the ones you cut out from the slab of mesh that you get from the companies. So I've never seen a patient with an orbital mesh extruded. And the second important thing is your cheek skin flap when you raise for Weber-Ferguson incision, it should be in a stepladder fashion. I suggest you read Converse, the technique described by Converse, where half the orbicularis is left on the lid, the other half of the orbicularis is left on the globe. So you read that so that your the thickness of that lid which you're lifting is still thick. So there are a combination of techniques where you place the mesh slightly more posteriorly. Earlier, the thought was the mesh will recreate the orbital ridge, but we've moved away from that. All that the mesh needs to do is to support the globe. So pushing the mesh slightly posteriorly, bending the mesh, avoiding sharp corners, avoiding, making the lid flap too thin, doing a step ladder sort of flap elevation, all of that makes a lot of difference.
Thank you, sir. Sir, in continuation for the above case scenario, Dr. Abhimanyu was saying they have planned a lattice-first dorsal free flap and the patient has only external carotid and IJV remaining. So I think they are going to anastomose with that.
That is fine. Doing a lats free flap is good because lats will give you good muscle, will give you good skin, good pedicle length. That's okay. If you have the external carotid, if it's not fine. See, the problem happens is that if the neck is very fibrous, and if you have to do, like if you have to separate the IJV to put a Setinsky or go around it to do an end to site, usually the vein lacerates and causes a lot of problems. It's not the non-availability of the vessel, it is usually the fibrosis that surrounds the vessels. And I've seen in a lot of cases that those who have a lot of fibrosis around the vessels tend to lose their flaps also. They tend to have more complications like, thrombus and delayed flap loss and things like that. So, you have to be careful. You always have to remember that it can be a delayed, there can be a delayed flap loss. There can be laceration of the IJ, which you cannot repair. And you must be able to do end to side without 360-degree freeing up the internal jugular vein. You should be able to use a Cooley clamp and then make a small slit on the IJV and do anastomosis. So I don't think it's a wrong idea. Doing the lats with the to the carotid and the IJV is quite good. That's fine.
Thank you, sir. So next question is by Dr. Hanpon. For maxillary reconstruction, how often do you use vein grafts?
If it's a fibula, we don't generally use. Like I said, keep the facial artery and facial vein high up. You'll still be able to do it. The only question is when you're doing DCIA and the other flaps, where you have to be prepared to do the anastomosis to the superficial temporal artery and vein. But if the vessel mismatch is too much with the superficial temporal artery and vein, you have to use the vein graft to go to the neck. I don't think it's a big mistake.
Okay, sir. That's
And
all.
one of the things that you can do for getting the vein graft is a good technique that was taught to me. So what you do is you can actually take the ALT pedicle, okay, just the ALT pedicle alone, and use it as a bridge between the fibula and the neck vessels. So you'll have both the artery and vein there, but the only issue there is the size mismatch. Because otherwise the vein, you'll have to take it, cut it, and then dilate it and do a lot of things. But using the vein as a vein graft is not a mistake, but I would prefer to do it to the superficial temporal artery and vein if I'm pushed to it.
Okay, thank you, sir. And so just one more question popped up from Dr. Vijayadharan, sir.
Yeah.
Flow through flap with ALT. I don't know what he was trying to say, but he just put up a message.
Vidya, the way that the ALT pedicle exits, where the ALT pedicle ends, is either it ramifies within the vastus muscle, or it ends up in an anastomosis around the knee joint. I don't know of any flow throughs like that. We can do a flow through fibula because the distal takeoff of the peroneus is there, and you can anastomose a second flap to that. We can do a flow through of the radial forearm because all of these have vessels which don't end in that tissue. But from the ALT point of view, either it ramifies into the muscle or there's one very thin branch which goes towards the knee joint. So I'm not sure if we, and what flap do you want to raise beyond that? I really, I don't think it's possible. It is possible, Vidya, if the pedicle is running in the space between the rectus and the vastus of the same caliber, you can, and your requirement for the skin stops above that. And then you have good size caliber of the pedicle, and you can anastomose a second vessel to that. So that is one, you know that the ALT pedicle, the way it ends is variable. So if you have the pedicle that is going in the space between the rectus and the vastus, it hasn't ended in the muscle. It is not becoming narrower. If you have that a scenario where the lumen of the descending branches is still good, you can anastomose a second flap to that. I think that's possible. Yes.
Okay, thank you, sir. So those are the end of the questions there.
Yeah.
And Dr. Chowdhury has been asking you about if you can mention a word about the acrovascular hands-on technique that goes in Amrita.
The course usually happens early in the year, but this year we have not had it. I will, once the course has been announced, whenever it is, I will put it up in the Yahoo group so that everybody knows about it and you're all free to attend. But this year it's not happening, but it will happen for next year, I think.
Okay, sir. That's it for today. And thank you, sir. So thank you for
Thank you
giving
all
us the
for your
webinar.
attendance and attention. Thank you so much.
Thank you.